بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Now we will discuss the last part of the skull base imaging, and this will deal with the posterior skull base. You know, the skull base, the posterior skull base is formed by the occipital bone, which is here in blue color, as well as the posterior part of the temporal bone, the petrous bone, and a small part of the sphenoid bone. Now, some anatomic details here you can see the clivus, which is formed by the basio-occiput and the basi-sphenoid bones, and it forms the posterior part or the dorsum celli. Then we have the occipital bone, and we have the, of course, part of the temporal bone, which is the petrous and the mastoid part. And here we have one of the, let us say, the largest foramen in the skull base, which is the foramen magnum. And some of other foramina include the carotid canal, and you see this carotid canal will transmit to the internal carotid artery as well as the sympathetic plexus. And there is a posterior and a little bit inferior to it is the jugular fossa. We'll mention it in details. And here you can see this is the canal for the internal carotid artery, and this is a groove in the body of the sphenoid for the artery. After passing through the canal, then it will go into the cavernous sinus, and after that it will divide in the supracellular area into the middle and anterior cerebral arteries. And here you can see the internal auditory canal, and you know that through the internal auditory canal passes the acoustic nerve as well as the facial nerve, and we have discussed this part particularly in the imaging of the petrous bone, but we'll have the details of this area which is relevant to our subject. And also here you can see, if you remember, the endolymphatic duct and sac, or the vestibular canal, which also may be the seat of one of the tumors affecting this particular system. And here you can see the temporal bone. This part, which is presented in red, is the tympanic part of the temporal bone, and you can see that it is laterally located in relation to the carotid canal. You remember from the previous lecture that this is the foramen ovale and this is the foramen spinosa. And also we have discussed the pterygoid canal, the median nerve, and many of these structures while discussing the issue of the middle cranial fossa. Then this is the petrous part of the temporal bone forming the petrous bone, and this is the squamous part of the temporal bone. Now, this is the internal jugular foramen, which is divided by a bony ridge known as the jugular spine into two components, the pars nervosa and the pars vasculosa. And through these parts, you can see here, you see the internal carotid canal, and this is the jugular fossa, this is the jugular spine, This is the pars nervosa, which transmits the cranial nerve number 9 and the inferior petrosal sinus, while this pars vascularis or vasculosa transmits the cranial nerve number 10, 11, as well as the internal jugular vein. And here you can see the internal jugular or the jugular fossa, which is more posterior and inferior to the internal to the carotid canal. And then you can also see the hypoglossal canal, which transmits the cranial nerve number 12. These are the communication pathways. In the internal auditory canal, you can see the cranial nerves number 7 and number 8, as well as the labyrinthine artery. This is the site of the internal auditory canal. The jugular foramen, this is the jugular foramen, will transmit the glossopharyngeal number 9, the vagus number 10, the spinal accessory number 11. And the stylomastoid foramen, of course, will transmit the facial nerve as well as the stylomastoid artery. This foramen is not seen here. The inferior petrosal sinus and the sigmoid sinus, I will show. Then you can see the hypoglossal canal. This is the hypoglossal canal, which transmits the 12th cranial nerve. The foramen magnum, the biggest skull base foramen, will transmit to the medulla oblongata, the anterior and posterior spinal arteries, as well as the vertebral arteries. Then most of the lesions of the posterior skull base are related to the petrous bone, and most of these lesions also have been discussed with the issue of the petrous bone, but will emphasize these lesions once more. Also, we will give some hints about encephalocele fractures and CSF leaks, skull-base deposits, the chordoma, meningioma of the foramen magnum, and finally some words about Paget disease and fibrous dysplasia. And this is a lesion which is not seen frequently in the clinical practice. It is known as petrous apex encephalocele. This is a rare form of cephalocele centered along the posterolateral aspect of the Meckel's cave. You know that on either side of the cella you can see the cavernous sinus. Posterior to the cavernous sinus, and you can see the Meckel's cave where the ganglion of the trigeminal nerve is present. Then, and in this area, you can see collections of CSF, and this is known as petrous apex cephaloceles. They are incidentally discovered and they are asymptomatic in most of the cases, but some of the patients may present by sensory neural the hearing loss. The contents of this cephalocele, in spite of its name, are only CSF, which will follow the CSF signal in all pulse sequences in the T1, and you see in the T2, and then the flare images, it will follow the signal of the CSF. Then you remember this basal encephalocele we discussed two times in the anterior cranial fossa and in the middle cranial fossa. This will occur through the middle skull base. It can pass through the region of the sphenoid sinus, and it may involve the pituitary hypothalamic axis. In this particular case, you can see some hypogenesis of the posterior part of the corpus callosum. We have discussed the CSF leak in the anterior cranial fossa, where injuries to the floor of the anterior cranial fossa, especially the cribriform plate of ethmoids, will result in CSF rhinorrhea. But here, injury of the petrous bone may result in CSF autourea, and in both conditions there is disruption of the dura secondary to the trauma and the fractures, and this will lead to CSF leak through the nose, and this is rhinorrhea, or through the middle ear cavity, which is autourea. And the CSF leaks can be traumatic or non-traumatic. The non-traumatic causes include tumors, infections, and some of the congenital lesions. Of course, the CT is the most important and valuable tool for diagnosis of the fractures of the temporal bone. And we have categorized these fractures into two types: the longitudinal fracture, which involves the longitudinal axis of the temporal bone, and the transverse fracture, which involves the anteroposterior axis of the vitreous bone. Some of these fractures will have many complications like affection of the ossicles, as you can see here in this particular case, where there is disruption of the oncodomalial joint. This is the head of the malleus, and this is the incus. As you remember, the joint in between is disrupted. The ossicles are surrounded by soft tissue density, which is most likely due to blood, indicating the presence of hemotympanum, and these arrows points to the presence of air in the vestibule, which is pneumolabyrinth, and air in the temporal fossa, which indicates the presence of pneumocephalus. And here you see a longitudinal fracture of the vitreous bone with more or less intact ossicles, but they are surrounded by soft tissue density representing hemotympanum, and also you can see blood in the mastoid antrum as well as in the mastoid hair cells. This is what we call a transverse fracture of the vitreous bone, and this is relatively uncommon. It represents about 25% of the temporal bone fractures, while the longitudinal fracture will represent about 75% of the fractures. The longitudinal fracture will affect the middle ear, while the transverse fracture, like this one, will affect the inner ear. And this arrowhead points to the facial nerve canal. As you remember, this is the site of the facial nerve ganglion, and this is the ascending and descending limbs. And here you can see the fracture. It passes closely to the vestibule as well as the facial nerve canal. And this is another example of a transverse fracture of the vitreous bone, along with many of other facial fractures like fractures of the ethmoids and fracture of the sphenoid sinus, as well as periorbital surgical emphysema. And here you can see a longitudinal fracture of the vitreous bone and some blood in the middle ear cavity. And also you can see this is the internal canal, and this is the cochlea, as you remember from the anatomy. In this patient, you can see a fracture in the occipital bone, and you see also another fracture. It may be the same fracture that has extended through the occipital bone, reaching the vitreous bone, and this is a transverse fracture which is involving the facial nerve canal, and this is also um, the fracture is running transverse to the apex of the vitreous bone, involving the internal canal and the vestibule. It passes very close to the vestibule, and this may contribute to the sensory neural hearing loss in this patient. Then we came to infections, and the most important infection here is what is known as malignant otitis externa, or necrotizing otitis externa, or skull base osteomyelitis. This is an aggressive infection usually seen in diabetic patients, and the most common contributing organism is the Pseudomonas, and this infection is usually not responding to antibiotics. It will involve the external hereditary canal as well as the adjacent structures, both bone and soft tissues. Then, if you see a lesion which is formed of soft tissue density, obliterating the external hereditary canal associated with an extracanalicular soft tissue component, as well as destructive changes on both sides of the canal, affecting the temporal part as well as the mastoid hair cells. This infection may extend deep into the parapharyngeal space. Then you may think of uh, uh, malignant otitis externa or necrotizing otitis externa. And if you inquire about the patient history, and very frequent you see that the patient is diabetic. And this is another example of otitis externa, where you see a soft tissue density centered to the external auditory canal, and the infection also extends deep into the parapharyngeal space in relation to the nasopharynx. You see the heterogeneous enhancement of the inflammatory granulation tissue. And this arrow points to the course of the facial nerve, which is surrounded here by fat. And in this particular, on this side, the facial nerve is most likely involved. Then we came to another lesion affecting the external auditory canal, which is the Langerhans cell histiocytosis. And this is one of the lesions that can be seen particularly in the children, and either separately or in association with multiple osteolytic lesions of the calvarial and facial bones. And the etiology of histiocytosis is unknown. There is infiltration of the soft tissues by histiocytes, and the involvement of the external and middle ear is common, but the involvement of the inner ear is rare. Then one of the, let us say, uh, diagnostic appearances of histiocytosis is a child with bilateral, almost symmetrical soft tissue masses centered to the region of the external auditory canal associated with some erosive changes of the related bones. And this is another example of a female child, 1.5 years old, and you see soft tissue masses centered to the extended canal with involvement of the squamous part of the temporal bone, lateral orbital walls, and this is informative or let's say diagnostic of histiocytosis. And histiocytosis may be differentiated from the inflammatory changes associated with mastoiditis, and if it presents aggressive bone destructive changes, it can be also differentiated from rhabdomyosarcoma and metastatic deposits. Bilateral involvement is diagnostic, as I have mentioned. If you see bilateral masses in a child centered to the occipit, the internal canals, then you can easily diagnose this histiocytosis. But if the lesion is unilateral, you may need the biopsy to confirm the diagnosis. The treatment is by surgery accompanied by radiotherapy, which gives a good results. Then we came to an important lesion, which is usually mistaken for tumors. And I have seen recently a case like this. You can see this lesion is known as apical petrositis or petrous epicitis. This is a rare complication of otitis media. The patient will have otitis media and mastoiditis, then the infection will extend uh, through the Dolores Canal, and this is the course of the canal itself. Then it will affect the apex of the vitreous bone. Uh, at that time, infection will start to erode the apex of the vitreous bone, and of course, you can see that the internal auditory canal, uh, the carotid canal, is very close to the site of the lesion, and also the clivus is very close. And in the case I have seen recently, there were erosions of the vitreous bone exactly similar to this appearance, associated with some erosive changes in the adjacent part of the clivus, and the diagnosis was a malignant lesion, and the differential diagnosis included the skull-base metastasis. But one of the important clues for this diagnosis is the presence of infection in the middle ear and mastoid on the same side of the lesion. And you can see in this case otitis media and mastoiditis associated with some soft tissue enhancement along the apex of the vitreous bone. Then this lesion is usually presented by a triad, which is known as Gardingo triad, composed of otitis media, abducent nerve palsy, deep facial pain. And this lesion may be complicated by meningitis, extradural abscesses, osteomyelitis, and of course, the cavernous sinus thrombosis, which is very close to the site of the lesion. Then here you see a typical example. If you look carefully here, this is not the destructive changes of a tumor. You can see some expansion and also some erosive changes. Part of the bone is still remaining intact. Then on the T1 weighted image, the lesion will be of low signal, and the T2 weighted image, the lesion will be of high signal. If you inject contrast material, the lesion will enhance, but it is frequently written in the literature that apical vitreositis do not enhance. Many of the article reviews insist on this particular issue that vitreous apicitis do not enhance with contrast material. But if you look to many cases on the internet, and you can see that this apicitis will enhance with contrast material. This is another example. You see the otitis media and mastoiditis and inflammatory changes of the apex of the vitreous bone. The imaging findings of apical vitreositis in the appropriate clinical context, then you are almost diagnostic. Another lesion, which is more frequently seen at the apex of the vitreous bone, which is known as cholesterol granuloma or cholesterol cyst. It is also considered one of the sequelae of chronic otitis media, but the association with otitis media is not essential for the diagnosis of this lesion. And the any irrigated part of the temporal bone may develop cholesterol granuloma. And you see that if the vitreous bone is irritated, it can be involved by the cholesterol granuloma. Cholesterol granuloma is the most common cystic lesion of the vitreous apex. And here you can see a cystic lesion, and this lesion is frequently bright in the T1 weighted image because of the cholesterol content. The patient may be asymptomatic, may present by conductive hearing loss, and may present by cranial nerve dysfunction, especially the seventh nerve or tinnitus. And this is the CT appearance of a cholesterol granuloma, where you can see a cystic lesion at the apex of the left petrous bone. This lesion is not enhancing by contrast material, but the very thin rim you can see around the lesion is the remaining part of the cortical bone of the petrous apex. The lesion is usually of bright signal in the T1 weighted image. If you inject contrast material, it will not enhance with contrast. And this is another example, a cystic lesion of bright signal in the T1 weighted image and less bright signal in the T2 weighted image because of the suppression of fat. Then if you inject contrast material, it will not enhance. And sometimes you can have a peripheral low signal rim of hemosiderin, and also you may see faint peripheral enhancement after contrast injection. Then any part of the skull base is not immune from metastatic deposits, and the diagnosis is usually reached by the well-known history of a primary malignancy. This patient had a destructive lesion in the left mastoid, and the patient is known to have bronchogenic carcinoma, then this is a metastatic deposit. And also here, this patient had a soft tissue mass, which is obliterating the external auditory canal and associated with some erosive changes of the bony margin of the canal. Then the remaining sections showed a lymph node that is on the same side of the lesion with necrotic center, diagnostic of metastatic node, and this was proved to be a squamous cell carcinoma of the external auditory canal associated with metastatic lymphadenopathy. And this is another example of extended canal squamous cell carcinoma, and you see the aggressive bone destructive changes of the skull base, and there may be also destruction of the floor of the posterior cranial fossa with intracranial extension. Of course, this lesion should be differentiated from malignant otitis externa by many factors. Number one, the clinical appearance of the lesion and the demonstration of pus coming from the externality canal in cases of infection. Number two, the issue of a diabetic patient. Number three, the signs of inflammation, which are usually associated with otitis externa. Number four, the uh, aggressiveness of bone destruction in cases of carcinoma. Then we came to one of the very famous lesions affecting the posterior skull base, which is the acoustic neuroma. Acoustic neuroma accounts for about 80% of the tumors found at the cerebellopontine angle, where 20% will represent a meningioma. This is the most common cerebellopontine angle enhancing lesion, that is the acoustic neuroma. A diagnosis depends on the presence of a mass, extraaxial, widening the ipsilateral cistern, extending into the internal auditory canal with variable enhancement. And this is an example. And you see this patient with right-sided hearing loss, big mass on the right side with an intracanalicular component, which is best seen in the enhanced images. In the diffusion weighted images, it will show it will show diffusion, free diffusion, similar to most of the tumors. Acoustic neuroma is known to have cystic components, and if you look to this example, this is a pre-contrast scan. And this is a post-contrast scan. You see the extra-axial location of the lesion by widening of the ipsilateral cistern, and also the lesion is extending inside the internal DT canal. You can easily discriminate this lesion from another commonly seen lesion at the cerebellopontine angle, which is the epidermoid cyst. You know that epidermoid cysts do not enhance, but if it is infected or have some inflammatory reaction, it may show marginal enhancement. And at that time, you need to separate both, and you go to the diffusion weighted images. The epidermoid cyst will show uh, very evident diffusion restriction, while the acoustic neuroma will show diffusion free. Then here you can see a good example of a cystic schwannoma at the cerebellopontine angle. Is bright in the T2 weighted image, but the enhanced image show this helpful appearance, which is a solid enhancing component of the lesion extending inside the internal auditory canal. Of course, the main differential diagnostic possibilities of acoustic neuroma will be the epidermoid cyst at the cerebellopontine, also the arachnoid cyst and the neuroenteric cyst. If the lesion is cystic like this one, if it contains a major component of cystic lesion. Bilateral acoustic neuroma is diagnostic of neurofibromatosis type 2, and you can see also in association with neurofibromatosis type 2 the peripheral neurofibromas, multiple meningiomas, and gliomas. Peripheral neurofibromata and the cafe au lait spots are typical of neurofibromatosis type 1, while neurofibromatosis type 2 is diagnostic by the presence of bilateral acoustic schwannomas together with some of these tumors. And this is the case of neurofibromatosis type 2, showing bilateral acoustic neuroma and a meningioma related to the petrous bone, another meningioma which is related to the occipital bone, and maybe a third one here. Then we came to the facial neuroma, which is a tumor arising from the facial nerve. It may occur inside the internal auditory canal or along the course of the facial nerve. Facial neuromas are considered rare compared to the acoustic neuromas. The incidence of intratemporal facial neuroma is only 1% if compared to the acoustic neuroma, which is 80%. This lesion usually affects the pregeniculate area, the facial nerve canal before the site of the geniculate ganglion. And also multiple lesions can be seen along the course of the facial nerve. These lesions will present by facial nerve paralysis and hearing loss due to compression of the acoustic nerve inside the internal auditory canal and some tinnitus. Facial nerve tumors account for 5% of all cases of facial nerve paralysis. Of course, you know the most common cause of facial nerve paralysis is Bell's palsy. And here you see an enhancing lesion inside the internal auditory canal. If you do not see this component, then you consider this is acoustic neuroma, which is far more common. But if you see the extension of the lesion and the enhancement along the course of the facial nerve canal, then you consider the possibility of the facial neuroma. And this is another example. This is T2. You can see a mass inside the internal canal. And here in the contrast enhanced image, you see the intracanalicular component, and this is very important, the extension of the lesion along the course of the facial nerve. This is very important. Then we came to one of the well-known lesions in the posterior skull base, which is the trigeminal schwannoma, which represents about, let us say, 7% of intracranial neoplasms. And the trigeminal schwannoma come after the trigeminal schwannoma are the most common, followed by trigeminal uh, and this is the acoustic schwannomas are the most common, followed by the trigeminal schwannoma and then the facial schwannoma. Acoustic schwannomas represent 80%, trigeminal 7%, facial schwannoma is only 1%. Then these lesions will present usually in the third to the fourth decades of life. They may be associated with neurofibromatosis type 2. And this is an example of a trigeminal schwannoma. It also contains cystic component. This schwannoma particularly have two components, one in the cerebellopontine angle and another component in the paracellular area, which will give the tumor the dumbbell shape configuration. And if you remember, we have discussed many of the diagnostic signs for this schwannoma in the section for the paracellular tumors. And here you see the lesion is of intermediate signal in the T1 and T2 with heterogeneous enhancement. The cystic component do not enhance. Also, we have a schwannoma that arises in the jugular foramen. You know, the jugular foramen contains the nerves, the cranial nerves from 9 to 11, and a schwannoma can arise from any of these nerves. And if you see a lesion which is centered to the jugular foramen, and the jugular foramen may be widened, but the bony outline of the jugular foramen is not destroyed, meaning that there is enlargement with a smooth margin of the jugular fossa, then you consider a benign lesion. And very multiple benign lesions occur in this foramen, like schwannomas of the nerves crossing through the foramen and also meningioma. Then you consider that in the differential diagnosis, meningioma and schwannoma of any of the cranial nerves coursing through the jugular fossa. And here, this is the jugular foramen schwannoma, the very well-defined lesion of intermediate signal in the T1, some bright signal in the T2, homogeneous post-contrast enhancement with no associated, without associated destructive changes of the jugular fossa. Then here, you see a homogeneously enhanced lesion that extends outside the jugular foramen with, let us say, some which looks like a dural tail, for example. Then the differential diagnosis of this lesion will include meningioma, schwannoma, paraganglioma, metastatic disease, and lymphoma. Of course, the paraganglioma and metastatic disease will initiate aggressive destructive changes in the jugular fossa. But in my opinion, these are the five lesions which can be seen or included in the differential diagnosis of a mass located in the jugular fossa. And here you can see a jugular fossa schwannoma. It has a cystic component outside the jugular fossa and another component inside the fossa with heterogeneous post-contrast enhancement. As we have mentioned that meningiomas occur anywhere in the skull base, in the anterior and middle and posterior skull base, it accounts for 14 to 20% of all intracranial neoplasms, and meningioma anywhere will show the same features of meningiomas, including homogeneous enhancement, presence of calcium, the dural tail, some of the signal behavior like any other meningioma and the CSF cleft sign and most of the criteria of meningiomas. But in cases of skull-based meningiomas, especially those occurring in tight spaces, they may initiate some sort of bone destructive changes. And the meningioma arising in the posterior skull base is assumed to arise from the arachnoid cells along the cranial nerves number 9, 10, and 11 within the jugular fossa. Meningioma is the third common jugular fossa mass after paraganglioma and schwannoma. Then if you see a jugular fossa mass, especially if it is associated with erosive or destructive changes of the margins of the jugular fossa, then you consider paraganglioma. Then you may consider schwannoma if the margins are smooth, and meningioma if you see some of the criteria of meningioma. Then 5% of posterior fossa meningiomas arise in the jugular fossa. And you remember, some of the lesions arise at the cerebellopontine angle, while others arise in relation to the tentorial leaflet, and the remaining part arises from the convexity meninges overlying the cerebellar hemispheres. If there are additional meningiomas or schwannomas, then you consider the multiplicity, I mean multiple meningiomas or meningioma and schwannoma, you consider neurofibromatosis type 2. Then meningioma anywhere will show all the imaging features of meningioma. And some of the meningiomas may infiltrate the surroundings, as I presented some of the cases that have destroyed the skull base and extended extracranially, pathologically proved to be meningioma. But you know that meningiomas have the tendency to produce hyperostosis or sclerotic reaction of the adjacent bones. Then meningioma also is known in the jugular fossa, in the jugular foramen, and it carries its name, the jugular foramen meningioma. And as written here, it is a common tumor in an unusual location characterized by diffuse skull base infiltration. And this is known as a centrifugal pattern, which may extend to involve the petrous, the temporal bone, including the middle ear cavity, the skull base, including the jugular tubercle, the hypoglossal canal, occipital condyles, and the clivus, with extracranial spread into the nasopharynx and the carotid space, and the intracranial extent is seen along the intracranial dura. I have presented some of the cases similar to what's written here, and if you look to these cases, you will never think of a meningioma, but you think of an aggressive lesion that is going every direction. But on the pathology, it proved to be a meningioma. Then you consider also meningioma if you see an extensive lesion like this involving the skull base. And this is a meningioma which is not different from a jugular foramen neuroma. It's a well-defined lesion, homogeneously enhanced, related to the jugular fossa with some dural tail and a creeping nature. Then uh, uh, these findings are compatible with a hypoglossal nerve schwannoma, but it included in the differential diagnosis uh, the schwannoma, as I have mentioned, but this was a neuroma. And this is the T2 weighted image of the same case. And cerebellopontine angle meningioma, we have said many times that in order to differentiate meningioma from acoustic neuroma, meningioma do not extend inside the internal canal. Meningioma show homogeneous enhancement with an enhancing dural tail. Meningioma will produce diffusion restriction, while acoustic neuroma will not show diffusion restriction. Both meningioma and acoustic neuroma may present by sensory neural hearing loss. But in this particular example, you can see that meningioma is extending inside the internal canal. Then how can you predict the diagnosis? There are several factors. Number one is the extension of the tumor inside the internal canal is secondary, meaning that the internal canal is intact with normal size and the regular cortical outline. If the lesion is acoustic neuroma, it will arise inside the extended canal, starting by destructive changes of the canal, then it may extend outside the internal canal. But you may say that some of the tumors will arise from the extracanalicular course of the acoustic nerve. Then you have another differentiating point, which is diffusion. In diffusion, meningioma will show diffusion restriction, and acoustic neuroma will show diffusion free. Acoustic neuroma will not show an enhancing dural tail, and acoustic neuroma do not contain calcium. And here in the jugular framing meningioma, here, this is the tumor which is of intermediate signal in the T1. It shows some faint contrast enhancement, and this may differentiate this tumor from the glomus tumor, which is enhancing strongly, as I will present some of these cases. And you see that the jugular fossa is not that well destroyed. Foramen magnum meningioma, and a well-defined intermediate signal mass compressing the craniocervical junction, intermediate signal in the T2, and homogeneous post-contrast enhancement. And this is the sagittal images well demonstrating the tumor at the jugular framing with the classic dural tail and homogeneous enhancement compressing the craniocervical junction. This is a meningioma at the jugular framing posterior to the spinal cord. It shows homogeneous post-contrast enhancement. Of course, the orientation of the lesions at the foramen magnum is better achieved in the sagittal images, since you can see the tumor and you can see the spinal cord as well. This tumor is of intermediate signal in the T1 and T2 with some post-contrast enhancement. Then we came to the jugular fossa glomus tumor or chemodictoma, which is, as I have mentioned, the most common lesion arising inside the jugular fossa. And this lesion will show aggressive, erosive, and destructive changes of the jugular fossa. It will present by tinnitus and hearing loss. This paraganglioma will enlarge in different directions, and one of the common directions is the middle ear cavity. The tumor will erode the bony ridge between the middle ear, and the jugular fossa will extend intratympanic, then hence the name jugulotympanic glomus tumor. It also will extend into the cerebellopontine angle and may destroy the skull base with extracranial extension. This is almost a diagnostic appearance of a jugular fossa glomus tumor with destructive changes of the jugular fossa by a mass, and this mass has extended into the external as well as the middle ear cavity with destruction of the posterior margin of the mastoid and with possible extension into intracranial. The glomus tumor will result in destruction of the vitreous pyramid with soft tissue mass in relation to the jugular bulb that may extend into the hypotympanum as well as the middle ear cleft. The mass may be associated with destruction of the ossicles, the otic capsule, the posteromedial surface of the vitreous bone. On MRI, you can see this classic appearance, which is known as the salt and pepper appearance, and this is not seen in smaller tumors less than 2 centimeters in diameter. But with larger tumors, you can easily see this salt and pepper appearance. On angiography, the mass is hypervascular with obstruction of the jugular valve by regular thrombosis or tumor thrombus. Some of these lesions may undergo malignant transformation, giving metastasis to the regional lymph nodes, and the incidence of this is about 3%. And if you see a lesion centered to the jugular fossa with destructive changes and erosions, think of a glomus tumor. And this is a good example of a glomus jugular tumor centered to the region of the vitreous of the jugular fossa with erosive changes of the related bones. And you can easily appreciate the intimate relation of the tumor to the middle ear cavity. On MRI, the tumor will show low signal in the T1 and bright signal in the T2. It will enhance significantly on post-contrast images. This is the appearance of the tumor on CT with enlargement of the jugular fossa and the erosive changes of its margin. On MR angiography, you can see a hypervascular mass which corresponds to the jugular foramen tumor. On selective angiogram, you can see the feeding vessels and the tumor blush, denoting hypervascularity, and this is after embolization. Then salt and pepper appearance will be identified in larger tumors and is not usually seen clearly in the smaller tumors. And here you can see very good example of a salt and pepper appearance. This is the T1 and this is T1 post contrast, where you can see the enhancement of the tumor and the classic appearance of the salt and pepper configuration. And this is another example. This is T1 weighted image, and this is a flare image, and here you can see the T1 post contrast. Of course, the what corresponds to the salt is the enhancing matrix of the tumor, and the paper corresponds to these dots of signal void, which represents the vessels going through the tumor matrix. And you remember we have mentioned some words about the skull base chondrosarcoma, and we said that it represents about 7% of the head and the neck chondrosarcoma, and there are some of the predisposing conditions like Ollier and Maffucci syndrome, and the most common location is the vitro-occipital synchondrosis, the suture between the vitreous and the occipital bones, and it may be seen also in the sphenoesmoidal junction or in the region of the sella turcica. Most of the skull-base chondrosarcomas are located off the midline, and this may help in the differential diagnosis of this tumor from chordoma, which is usually present in the midline. And the tumor will contain matrix calcification, and this is one of the diagnostic criteria. And the second diagnostic criterion is the presence of very bright signal of the tumor in the T2 weighted image approaching the signal of fluid. Here in the CT scan, you see a lesion at the apex of the vitreous bone with matrix calcification. Calcium is not well appreciated in MRI. The tumor is of intermediate signal in the T1 and considerable brightness in the T2 weighted image. If you inject the lesion with contrast, it will enhance significantly. And this is another example of a chondrosarcoma affecting the region of the apex of the vitreous bone in a male patient 30 years old with right-sided hearing loss, ophthalmoplegia, and multiple cranial nerve pulses. The tumor is bulging into the sphenoid sinus. The tumor is infiltrating the cavernous sinus, and this will explain the multiple cranial nerve pulses. The tumor is displacing the internal carotid artery anteriorly. The artery is still showing the normal signal void, denoting its patency. Also, the tumor has infiltrated the region of the Eustachian tube, and this will explain the fluid accumulation in the vitreous bone and also explain the right-sided hearing loss. And after contrast injection, the tumor enhances significantly, either homogeneous or heterogeneous. Then you see this is the T1 before injection of contrast, and this is after contrast injection. In the coronal plane of another patient, 60 years old, you see a tumor that is located at the apex of the vitreous bone. Part of the component is in the paracellular area and another part in the cerebellopontine angle area. The tumor is, let's say, very bright in the T2 weighted image and it shows significant contrast enhancement. This is the internal carotid artery, which is markedly displaced laterally. And here is the post-contrast axial images. You see the components of the lesion, the involvement of the infratemporal fossa, as well as the pterygoid muscles, the extension intracranially in the temporal lobe, which is better seen in the coronal images. Then this is another example of chondrosarcoma related to the apex of the vitreous bone with aggressive destructive changes in the skull base, especially the vitreous bone and the clivus, with extension into the sphenoid sinus, intracranial extension in the temporal fossa, as well as in the posterior fossa, with compressive effect on the brainstem and the fourth ventricle. There is the destruction of the clivus with almost total obliteration of the sphenoid sinus with destruction of the right mastoid hair cells which contain some of the fluid signal, invasion of the temporal lobe with perilesional edema, and you know that if the tumor is still separated from the brain tissue by meninges, there should not be a brain edema around the tumor. But if the tumor has invaded the brain parenchyma, and you will consider some of the reactive brain edema to the tumor. And the differential diagnosis of skull-based chondrosarcoma will include chordoma, and the chordoma will show also very bright signal in the T2. It will also contain some of the calcific elements or bone debris. Meningioma contains calcium but is not bright in the T2 weighted image. Metastases do not usually contain calcium, and the non-primary malignancy will help in the differential diagnosis. Esophageal carcinoma, the lesion is centered to the nasopharynx without the presence of calcification. Pituitary microadenoma Calcium is uncommon in the pituitary lesions, and the tumor is totally confined to the pituitary sinus. Cavernous sinus hemangioma is not an aggressive lesion. It may be bright in the T2 weighted image, and it does not contain calcium. This tumor is an aggressive tumor in the vitreous bone with destructive changes and extra osseous soft tissue component compressing the cerebellum. In the differential diagnosis, you may include chondrosarcoma, include lymphoma of the skull base or metastasis to the skull base, and this tumor has been proved to be a malignant endolymphatic sac tumor. It's considered a rare lesion, but one of the lesions that can occur in this particular area. The differential diagnosis may include glomus, jugular, chondrosarcoma, metastatic deposit, and this endolymphatic tumor. And skull base chordoma, the chordoma in the skull base will occur in the in the clivus, and it may extend into various directions. The chordoma is usually seen in the midline, but you know that there is a known entity, paracellular chordoma, and also the chordoma can occur in the in in the region of the clivus. Chordoma accounts for about 6% of primary bone tumors and is treated by resection followed by irradiation. Chordoma are resistant to conventional chemotherapy. The skull-base chordomas are usually located in the upper part of the clivus, and it may extend to the lower part of the clivus, posterior clinoids, and the cavernous sinus. Sometimes arises at the craniocervical junction and may involve the atlas and axis of the upper cervical vertebrae. The bulk of the tumor is usually located in the midline, which may help in the differential diagnosis from chondrosarcoma. Chordoma are slowly growing extraaxial lesions. And many times you see some, let us say, calcific spots within the tumor, which may represent actual calcium or the sequestrated, destroyed bone fragments from the apex of the vitreous bone or the skull base. And this is a chordoma which will show variable signal from hypo to intermediate in the T1 weighted image. And the T2 weighted image, it will show bright signal intensity similar to the chondrosarcoma in many times. Hypo intensity within the tumor may represent areas of degeneration or hemorrhage or calcium. The tumor will enhance markedly if you inject contrast material. And of course, this is one of the good policies in imaging on the skull base is to have fat suppressed images before and after contrast in order to see the actual tumor extent. Metastases occur in about 20% of chordomas, usually to the lung, to the bone, skin, and liver. Chordoma metastases have similar imaging characteristics similar to the primary lesion. The prognosis is related to the local disease extent and the presence or absence of metastasis. The differential diagnosis of chordoma will include chondrosarcoma of the skull base, plasmacytoma, meningioma, pituitary adenoma, and this entity, the benign notochord cell tumor. This is a skull-base chordoma infiltrating the region of the clivus, extending lower down to involve the skull base, the region of the foramen magnum, and maybe the first cervical vertebra. Look to the brightness of the tumor in the T2 weighted image. And this is another example of chordoma of the skull base infiltrating most of the clivus. This is a small part remaining then going down to involve the craniocervical junction, totally encasing the upper cervical vertebra. This is C2 uh, cervical vertebra. This is a skull base chordoma, which appears of intermediate or dark signal in the T1, very bright signal in the T2 weighted image, and it does not show significant enhancement in the post-contrast image. This is the axial T2 weighted image showing the very bright signal of the chordoma. Then finally, we came to the some words about the fibrous dysplasia and the Paget disease. We have mentioned a lot about fibrous dysplasia in the section of anterior and middle skull base. Then this is, as you all know, a developmental abnormality that can affect any bone, and the major diagnostic features include expansion of the involved bone and the ground glass appearance of the expanded bone. The skull and the facial bones are affected in about 10 to 25% in patients with monostotic fibrous dysplasia. Monostotic means that the lesion affects a single bone, or polystotic fibrous dysplasia will involve the skull and facial bones in about 50% of the cases. The typical ground glass appearance is one of the helpful criteria for the diagnosis of fibrous dysplasia. You should remember that fibrous dysplasia will show metabolic activity both on bone scan and PET CT. Then fibrous dysplasia may show sarcomatous transformation in less than 1% of the cases, usually towards the osteosarcoma. It is a very good policy to diagnose fibrous dysplasia by CT or even by plain X-ray, but fibrous dysplasia is a challenging diagnosis on MRI. And you see here in the T1 weighted image, there is expansion of the squamous part of the temporal bone as well as involvement of the petrous bone. But in another patient with posterior skull base fibrous dysplasia, you can easily see the two major diagnostic criteria: expansion and ground glass appearance. And this is a classic case of fibrous dysplasia. And you see the involvement of the anterior skull base, the middle skull base, and the posterior skull base, including the petrous bone. Another case of fibrous dysplasia affecting the basi-occiput and the clivus and also the posterior ethmoids, involvement of the posterior and the middle skull base. Finally, Paget disease is one of the lesions that can affect the skull base. The etiology is unknown. It may be thought as a viral infection or genetic susceptibility. There are three stages of Paget disease: the lytic phase or the lytic stage, in the mixed lytic and osteosclerotic, and the sclerotic phase. Paget disease affects about 4% of individuals over the age of 40 and up to 12% of patients above 80 years of age. Then there is a slight male predilection and considerably higher incidence in UK and in some other countries. The major diagnostic feature of Paget disease is bone enlargement. Most of the patient may be asymptomatic, but symptoms may include pain and tenderness, localized hyperemia, increase in the size of the bone, bowing deformities, and kyphosis of the spine. Osteoporosis circumscripta means one of the descriptive terms for Paget disease means the presence of large, well-defined lytic lesions affecting the calvarium and other parts of the. Then cotton wool appearance, which is the combination of lytic and sclerotic lesions of the skull, the bluic space widening, the space between the inner and outer table is widened and extensively affected. Then the deformities of the skull base may give the appearance of this well-known hat, which is known as the Mo Shantar hat. And this is what we call the Shantar sign, where the skull is enlarged and this frontal bone will protrude anteriorly like the hat. But you do not need the sign to diagnose Paget disease. Paget disease is diagnosed primarily from the enlargement of the bone. And here you see significant enlargement of the calvarial bones with widening of the diploic spaces and what's known as cotton wool appearance. This is the plain X-ray and this is the sagittal reformatted CT image. The Paget disease will affect the inner and the skull, the inner table and the outer table. It may show these cotton wool spots, which are not so so well appreciated in this lateral X-ray of the skull. Complications of the Paget disease will include osseous weakening, results in deformities and fractures, increased risk of osteoarthritis in many of the joints, neural compression leading to deafness, which is considered the most common complication, cranial nerve pulses, basilar invagination due to bone softening of the skull base, hydrocephalus or brainstem compression. Secondary transformation into malignancy, like osteosarcoma, is in the range of 1% of the cases. High output congestive heart failure due to the hyperdynamic circulation reaching the bone, and hyperparathyroidism in about 10% of the cases. Thank you very much. Alhamdulillah Rabbil Alameen.